and welcome to Beyond the Scales, starting the obesity conversation, where we unravel the complexities of obesity. I'm Emily, and I'm joined by my co-host, Fran.
Hi everyone, we're two medical students on a mission to demystify obesity, as there's so much more to it than just a number.
We're joined by Consultant Bariatric Surgeon, Mr Lee Humphreys, who's working with us with this podcast. He brings a wealth of clinical expertise to help us navigate this complex condition. Hi Lee.
Hi Emily, hi Fran. What are we talking about today?
So we were having a chat before and we're thinking maybe doing an overview of health consequences related to obesity. So we're thinking maybe the easiest way is to kind of do it system by system. So could you tell us a bit about the effects related to the heart?
Okie doke. So, that's a good place to start. So the cardiometabolic consequences of obesity are probably the ones that are most well documented and the ones that most people know about. So things like hypertension, raised lipids, cholesterol, heart attacks, strokes, these are all very closely correlated with obesity. And so there's some of the diseases that we have the ability to impact on by treating obesity. And there is published evidence that shows that if we treat people's obesity, we can reduce their risk of significant cardiometabolic events in the future. So it's certainly a very important cause of obesity-related disease, and cardiac disease is still amongst one of the biggest killers in the world. So,
and in terms of kind of progression rates, and is the obesity development, does that go alongside kind of cardiovascular disease? Do they go up in parallel, or does one come first? Or
yeah, so I think the metabolic changes that occur as a result of obesity then drive the development of cardiac disease. So the physiological changes that happen because of excess fat storage drives hypertension, drives raised cholesterol, raised lipids, which then leads to the increase in heart attacks, strokes, ischemic heart disease, that sort of stuff. So, of course, you can have those things without being obese, but they are more prevalent in patients, people living with obesity. And it's the underlying obesity pathological changes that drive those mechanisms.
Okay. I found that many patients, particularly older patients, are quite vigilant and aware of what their cholesterol levels are. What do you think about the younger generation and obese patients? Are they aware of their cholesterol levels and the impact this has, and how do you tell them about it?
The answer is most of them probably aren't, because it's not something you get symptoms from, rather. And, we don't routinely check people's lipids.
No.
When you get the pleasure of turning 40, I remember being invited for my first 40-year-old well man check by the GP. And then you go along and they do your height, weight and BMI, and I had my blood pressure checked, and I had my cholesterol done as part of that. And then I think I get invited back. But, unless you've been in hospital or been to the GP and had bloods done for other things that they may then incidentally have checked your lipids or done your blood pressure, then most people who are sort of, in their 20s and 30s won't be aware. And to be fair, most people in their 20s and 30s, even if they're living with obesity, probably haven't developed significant problems at that time, because these changes do take time. They don't happen very rapidly, but, it's all about that increased risk. But do we check routinely obese people for those things? No, I don't think we do.
And I'm assuming the exception in these cases are patients with, conditions like familial hypercholesterolaemia and genetic conditions.
Yeah. So if there's a reason why you would check that first, because if you know they're at greater risk for another cause, such as you've discussed, then yes, you may well be checking it. But, the majority of people out there living with obesity don't have those things. And so they're not getting them tested or checked.
Okay.
Yeah, so you did mention strokes there as well. Is there something behind that you could explain more about? So why you increase risk of strokes?
Sure. Well, again, I'm definitely not a stroke physician, but it's about, the risk factors for stroke. Some of them, as we know, are hypertension, raised lipids, the same as they are for arterial disease anywhere else. So it's the same underlying mechanisms that drive strokes and cardiac disease. So, I mean, my basic understanding of it is it's those pathological processes drive these things across different organ systems.
And one of the main reasons that we started this podcast, wasn't it? Because obesity comes under so many topics within our new MLA exam, which we do at the end of medical school now. Another topic which it comes under is liver diseases and gallbladder disease in particular. Do you find that nearly all of your patients, particularly when they're coming up close to their bariatric surgery time, is it kind of a unanimous thing? Are all patients affected by gallbladder or liver disease or not?
Sure. So gallstones are very closely associated with obesity, and it's one of the main risk factors. So plenty of people who come for laparoscopic cholecystectomy for their gallstone disease are in the overweight or obese range. Very closely associated also is what used to be called non-alcoholic fatty liver disease. Recently, it's been changed to metabolic dysfunction-associated steatotic liver disease, because it's much easier to say. But it's very common. And what happens is we have a limited ability to store subcutaneous fat. So adipose tissue is a safe place to store fat. And it's one of the reasons why some people can carry a lot more fat than other people, but yet not have metabolic disease. Once you exceed your ability to store fat safely in adipose tissue, it then starts to be put in places where it causes harm. And one of the first places it goes is into the liver.
Yeah.
And this is, for most people, entirely asymptomatic. So they know nothing about it. So it can get picked up then as part of the process for screening people for gallstones. So, for example, you go to your GP with some abdominal pain and they might request some bloods. And so you might notice a raised ALT, that, although that's not specific at all, but it's very common to see that in people with fatty liver disease. Yeah. But also when they do the ultrasound to look at the gallbladder, more often than not, the ultrasonographer will comment on whether the liver looks fatty or not.
Yeah.
And so fatty liver disease is a real problem, and the rates are rising. For some people, it can progress to cirrhosis in the worst case. And I believe now that fatty liver disease has overtaken alcohol as the leading cause of cirrhotic liver disease in the UK. Mm. And it's also driving a rise in hepatocellular carcinomas in young women. So obesity is underpinning these serious diseases as well.
And do you think there's enough awareness about this? Because until recently, I hadn't really heard about the link with liver disease. So do you think patients are aware of this risk?
No. And what I tend to see is I see people in clinic about their gallstones, which they will know about because that's why they've been referred. But more often than not, even if the ultrasound mentions fatty liver, that hasn't been explained to them by the person who requested the ultrasound. It's not mentioned. And I will often use that as a way to ask whether they were aware that this is happening, and that as a route to potentially offering them a referral into a weight management program if they meet the criteria to help them. Because fatty liver disease can be reversed with weight loss. Not cirrhosis, but the vast majority of people don't have cirrhosis. It's a continuum. If you get there early enough, you can reverse it. Now, it needs significant weight loss. Most people think probably in the region of 10 to 15% to reverse it. Right. So patients will come, and most patients don't regard gallstones as a serious condition, which it isn't for most people. But when you start talking to them about liver disease, they start to realize that they may have the potential to develop a serious problem in the future. And at that point, they may be willing to accept help for their obesity. But again, if you don't have the conversation, you're missing an opportunity.
Yeah, and 10 to 15%, that's quite a significant amount of weight to lose.
It is.
Yeah.
It's very, very difficult for the vast majority of people to lose 10 to 15% of their body weight and crucially keep it off without surgery or medication to help.
Yeah, we mentioned it in another episode, didn't we? But the psychological challenge of that as well is quite a big one. Another question I had was about the cirrhosis. Is that ever a contraindication to surgery? Does it ever stop bariatric surgery from happening? Or
so cirrhosis, liver cirrhosis, is a pretty serious medical condition, and it does, in its later stages, certainly massively increase the risk of any type of abdominal surgery. So you may have heard about the Child's-Pugh classification of cirrhosis. I'm not an expert, but the earlier stages are Child's A. Now, for most people, you can operate on them with Child's A cirrhosis. It definitely increases the risks, but it's not an absolute no-no for most people if they're otherwise reasonably fit. Once you get into more advanced cirrhosis, then the risks of surgery probably outweigh the benefits.
Is that then more of a conversation as well between you and the anaesthetist and kind of making that decision?
Well, it involves the anaesthetist and it involves the patient. I mean, it will often involve hepatologists, but the risk of people going into decompensated liver failure after surgery also significantly increase risks of bleeding and other immediate surgical complications are very high in people with significant cirrhosis. And for most people, we won't operate on them because the risks are so high. It also depends on the type of surgery, but all of this needs to be part of a very careful conversation involving the patient, surgical team, often anaesthesia, and often hepatology.
And we've read about it quite a bit, haven't we, about how obesity does increase your mortality risk in general as well. Is that a conversation that you find that you have, Lee, or is that more of a conversation that the patient will have with their GP?
I don't know what conversations patients have with their GPs, but I suspect infrequently is that discussed. Although sometimes it might be if a GP is trying to persuade someone to seek help. And it's interesting, isn't it? We up until very recently we talked about morbid obesity as a term. We're now moving away from using that terminology, but there is no doubt that severe obesity is a life-shortening disease. And when I see patients in clinic for bariatric surgery, the first question I ask them is, why have you come for surgery? Why now? Because it's a big decision and it interests me as to the motivation. And a significant number of people will say to me, it's because I want to live longer for my children or my grandchildren. That's such a common theme that I hear. Now, that obviously the group of patients that I'm seeing are a selected group. They've been to a tier 3 weight management program. They've made the decision to come to bariatric surgery. So they've been informed about the health risks of obesity and the potential benefits of treating their obesity. So they're informed. And they're only a small number of the people living with obesity out there. So I can't say that holds for everybody, but certainly in the group seeking treatment, that's a very common theme.
And we've touched on this before, but everyone knows there's quite a strong link between type 2 diabetes and obesity. You've mentioned after bariatric surgery, some patients can go into remission. So is that more to do with the kind of physical surgery than weight loss, or how does that work?
So that's a great question. And the honest answer is the exact mechanisms aren't fully understood. But, currently, bariatric or metabolic surgery, as it's called in this scenario, is the only intervention known that can induce long-term remission in type 2 diabetes. And what do we mean by remission? Well, remission means putting your blood sugars into the normal range without requiring any medication. So we don't talk about a cure. because even in people who go into remission, their diabetes can come back further down the line. And you can have a complete remission, which is what we've just discussed, or you can have a partial remission, whereby you still need some medication to maintain your sugars in the normal range, but less medication than you needed prior to having surgery. And what's really impressive about surgery is the sort of speed of onset. So you can literally come in on the morning of surgery as a type 2 diabetic, have your surgery, go home the following day, and be off all your medication with sugars in the normal range. And that's really quite dramatic and impressive. Now, what we can't do is predict on an individual basis who will get a complete remission, who will get a partial remission, and indeed how long that remission will last for. But there are certain things that you can use that are predictive of a longer term benefit. So the earlier you operate on people after their diagnosis of type 2 diabetes, and certainly within the first 4 years, that group has a very high chance of going into remission. The less medication you're on for your diabetes, and particularly those who are not on insulin, they have a much greater chance of getting long-term remission. That doesn't mean there's no benefit to patients who get a partial remission. There is still a significant benefit. But it's really quite powerful.
Quite amazing, isn't it? And life-changing to...
Yeah. So the early mechanism there is almost, it has to be hormonal. That's not weight loss. You're not losing weight in one night.
Yeah.
And we know that after certain types of surgery, particularly gastric bypass, your GLP-1 levels go up very significantly. And we know from the pharmacology that GLP-1s are a treatment for type 2 diabetes and are now being used to treat obesity. So GLP-1 levels going up is probably one of the mechanisms by which metabolic surgery impacts on your glucose control. Now, how the longer term effects are mediated, that may well be weight loss related, because obviously the weight loss takes time. And as the weight comes off and stays off, then that's probably the sort of longer term benefit that helps keep your diabetes in remission.
Yeah, and I imagine that would have such big effects on quality of life, because complications of type 2 diabetes.
Yeah, and I mean, it'd be, cheaper for the patients they don't have to pay for the medication now.
Yeah,
so.
as well.
Yeah, so the financial argument for metabolic surgery in type 2 diabetes was put to bed a long time ago. So in the UK, the NHS gets its money back in around 3 years in a type 2 diabetic. Patients still need their annual diabetes check. Because we said we can't talk about a cure, so you still need that. But the money is saved in reduced medication and reduced doctor visits for the other complications of diabetes. And even then, if your diabetes comes back down the line, there are multiple papers showing that any period of your diabetes being in remission actually translates into longer term health benefits and reduced risk of cardiovascular disease and other things that go along with diabetes.
And kind of on the topic of quality of life, we were talking yesterday about sleep apnea and how that can have a big effect on patients. Could you tell us a bit more about that?
Yeah, so sleep apnea is another condition that's very closely associated with overweight and obesity. And as you know, it manifests itself in usually with patients feeling very tired during the day all the time, often falling asleep at inappropriate moments. And in extreme cases, people can fall asleep while they're driving and things like that. Right. So it's a condition that does have some quite serious consequences. And sleep apnea that's untreated is associated with an increased risk of cardiac death. Now, the treatment for sleep apnea in the first instance usually is CPAP, so continuous positive airways pressure. So that involves a tight-fitting mask that goes over your face that you wear at night. And sleep apnea can have really significant impacts on people's relationships. So first of all, patients with sleep apnea tend to be very heavy snorers, and often partners will end up sleeping in another room because the snoring is so bad. Then you get your sleep apnea treated, but the snoring is replaced by the noise of a CPAP machine. And so they're not particularly quiet either. So they do have quite significant impact. So But the good thing about sleep apnea is in the vast majority of people with significant weight loss, the sleep apnea is reversed and there's no longer a need for a CPAP machine when the weight comes off and it stays off. So again, it's one of the comorbidities that is very easily reversible with significant weight loss.
Yeah, that's it's quite a scary condition, and it's that's now that you talked about with the driving. It was actually a past paper question that I came across the other day.
Was it?
Yeah. It was a lorry driver, and it was saying, it had a list of his comorbidities, and he fell asleep behind the wheel, and why? What is the predisposing reason as to why that happened? And the answer was sleep apnea.
Yeah, so patients coming into our Tier 3 management service in Plymouth will get screened for sleep apnea because a lot of people don't know they've got it.
Yeah.
And so if they score highly on a screening assessment, we then send them off to the sleep clinic for a formal assessment to establish whether or not they have got sleep apnea as a diagnosis. Because if they've got it, they need to be started on treatment. Because when they come in for surgery, they need to bring their CPAP machine in for the night after surgery, because if untreated CPAP has some increased risks perioperatively related to anaesthesia and that sort of stuff afterwards. So it's important that we know if someone's got it and make sure they're treated if they do.
Okay, well, I think we'll end this podcast here.
It was a good brief overview, wasn't it? And we'll go into detail in further episodes, I think.
Yeah. No, it was great. Well, make sure you all like and subscribe. And, if there's anything that you want us to discuss, topics, please send them in and let's see what we can do.
Yes, please do.
Yes. Thank you for watching.
Thanks very much. Bye.